got a knock joke for you today. Knock knock. Who's there? Amos. Amos who? A mosquitoes. Hello everybody, it's Ryan here. Hope you and your family are well. Today we're discussing a very important topic, malaria. Thanks for joining me. This is the outline of our talk. We're going to be covering a clinical case to give us some perspective. Then we're going to be breaking down malaria in terms of a handy introduction, etiologies, patient presentation, including signs and symptoms to look out for, differential diagnosis, diagnostic evaluation, treatment and management, prognosis, complications. Then we're going to talk about the Bible. Thank you so much for joining me. Hope all is well with you and your family. Let's get started, everybody. Got a 22-year-old woman who left her home in Nigeria 2 nights ago and started to develop fevers while on the plane. On landing, her family was concerned due to her deteriorating mental status. She is now confused and lethargic. Physical exam is notable for a temperature of 40 degrees Celsius, heart rate of 145. She's severely tachycardic and a blood pressure of 105/62, so she's hypotensive. Thin smear for malaria is shown on the next slide. We'll have a look. How should you treat her? Do you want to give her IV artemether, IV artesunate, IV quinidine, IV quinine, or oral mefloquine? Nice to ask. There's our beautiful thin smear. Okay guys, let's talk about malaria. So human malaria, as you know, is a febrile illness caused by either one of 4 species of malaria. So the Plasmodium brothers, right? Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae. We also get Plasmodium knowlesi as well. Now, most cases, by and large, worldwide, are caused by either Plasmodium falciparum or Plasmodium vivax. All right, Plasmodium falciparum is what we have here in sub-Saharan Africa, and that causes the most severe, the most fulminating kind of disease. Other forms just cause a milder flu-like illness. Mixed infections also occur. Now, malaria infection rates have been increasing worldwide over the past several years. It is mainly a disease of the developing world. In recent years, there have been concerns about the increasing resistance of malarial parasites to our antimicrobial therapy. So here, as we can see, this demonstrates the distribution of malaria worldwide. So in gray, we have Plasmodium falciparum, which you can see is basically most of Africa, right? Especially in the tropics, but most of Africa, right? And Plasmodium vivax is in the orange. We can see parts of Central and South America, and India, parts of Asia, right? So vivax and falciparum, more prevalent worldwide. Breaking it down locally in terms of our beautiful country of South Africa, falciparum malaria, right, is the way to go. Now here we're looking at risk. So the areas in yellow correspond to low risk, and the areas in orange, moderate risk. So we see parts of northern KwaZulu-Natal, right, especially bordering Mozambique, right, that's especially high risk and moderate risk, and the lower risk is parts of Limpopo and the northern portion of South Africa. Okay, let's talk about epidemiology and etiology. Malaria occurs in most tropical areas of the world. Between 300 to 500 million cases occur annually, quite a staggering number, with about 700,000 to upwards of 2.7 million deaths, mostly in kids. Now, Plasmodium falciparum predominates in tropical Africa, Southeast Asia, Oceania, Haiti, Amazon Basin, Dominican Republic. Plasmodium vivax is more common in Central America, Middle East, and in India. Plasmodium malariae in West and Central Africa, and ovale in parts of Africa. Right, if you have to break it down head to head now, talk about this quickly. So, looking at the characteristics of Plasmodium in terms of a variety of headings, right? So let's just get my pointer in there. So Plasmodium falciparum, the duration of the intrahepatic phase is 5.5 days, right? Versus about 8 days in vivax, 9 in ovale, 15 in malariae. The number of menozoites released per infected hepatocyte is 30,000. So it's probably double in Plasmodium falciparum versus the other types of Plasmodium. Approximate duration of the erythrocytic cycle is 48 days for falciparum, 48 for vivax, 50 for ovale, 72 for malariae. Red cell preference in falciparum is younger cells, but can really invade cells of all ages, whereas Plasmodium vivax has an affinity for reticulocytes and cells up to 2 weeks old. Morphology in falciparum malaria is usually only the ring forms, banana-shaped gametocytes. But in vivax, it gives rise to irregularly shaped large rings and trophozoites. Enlarged erythrocytes, we have Schaffner's dots. Ovale, we have infected erythrocytes with enlarged and oval tufted ends, Schaffner's dots. Malaria gives us band or reticular forms of trophozoites common. Pigment color in falciparum is black versus yellow-brown or dark brown in vivax and ovale, and brown-black in malaria. Ability to cause relapses, vivax and ovale, yes, because they have the ability to produce hypnozoites in the liver, which can persist for a long time. Pathophysiology, guys. Transmission is predominantly via the bite of an infected female Anopheles mosquito. Other mechanisms of transmission include blood transfusion, congenitally acquired disease, sharing of old contaminated needles, and organ transplantation. Now, if you look at the exoerythrocytic stage, here we have sporozoites, right? And they are transmitted via the bite of the infected Anopheles mosquito, and these are transmitted through to humans. Now, they travel to the liver via the bloodstream, invade the hepatocytes, divide and mature into schizons, each containing thousands of daughter metazoites. Now, the liver schizons rupture and release the metazoites into the bloodstream. Looking at the erythrocytic stage, here the metazoites invade the red blood cells. And this is where Plasmodium vivax and ovale are dangerous because they can remain dormant in the liver in the form of hypnozoites and can reactivate after months on end. This is a beautiful diagram from Harrison's illustrating the life and times of malaria. So we divide the life cycle into the pre-erythrocytic stage, the asexual erythrocytic stage, and transmission, right? So in transmission, we know that we have gametocytes, right, which are male and female gametocytes taken up during a blood meal. Right? Mosquito takes it up after a bite, after a human bite, and then in the gut of the mosquito, the gametocytes fuse and form a zygote, forming an ookinete, and eventually we get sporozoites. Sporozoites are undergo the process of reinfection of the human during a blood meal, and then they give rise to the portion of the life cycle in the human, right? So these are defenses here, which are meant to protect us and against these parasites. Antibodies to the sporozoites block invasion of the hepatocytes. This happens during the pre-erythrocytic stage. And also CD4 and CD8 plus T cells kill the intrahepatic parasites. So from the blood, they go through to the liver, and in the liver, they are then released into the bloodstream and invade the red blood cells, right? The sporozoites mature. They produce schizons, and these schizons then are going to get together and they rupture to produce metazoites, which infect more red blood cells, and that forms more schizons and more metazoites, and more red blood cells are infected, and it's a vicious cycle essentially. But some of these metazoites will then undergo transformation into gametocytes, male and female gametocytes, which is taken up by the mosquito again, and the life cycle continues, right? Under the asexual erythrocytic stage, we have antibodies which are targeting the malarial toxins, antibodies to parasite antigens on infected red blood cells which block cytoadherence to endothelium and augment splenic clearance. Under transmission, we have cell-mediated immunity and antibody-dependent cytotoxicity to kill the intraerythrocytic parasites. Antibodies that block fertilization, development, and invasion. So at each point here in this the life cycle, our body is trying to protect us against malaria. But these parasites have evolved mechanisms to evade or to bypass these and to continue replication. All right. Looking at patient presentation, how do patients with malaria present? Clinical symptoms are acutely similar in all malaria species, right? Patients without immunity, which means patients who have no prior infection, have the highest degree of parasitemia and the most complications. Symptoms develop only during the erythrocytic stage, only during the replication within the red blood cell stage. Fever is probably universally present. Other symptoms include chills, headache, sweats, myalgia, fatigue, nausea, abdominal pain, vomiting, diarrhea, and cough. Right? Symptoms can have cyclical patterns indeed. Anemia and splenomegaly, sometimes splenic rupture, hepatomegaly, and jaundice can ensue. Now, Plasmodium falciparum causes the most severe illness, and that's the kind that we have here in South Africa or sub-Saharan Africa. The risk of severe disease is highest, as we said, among non-immune persons, kids, and pregnant women. Very important to note, guys. This is taken from our local malaria guidelines here in South Africa. Right? So high-risk groups for malaria include pregnant and postpartum women, infants and young kids, the elderly, so extremes of age, right, especially those above 65. So the very young, the very old, splenectomized persons, immunocompromised persons, including HIV positive, and persons with comorbidities, right? Danger signs to look out for means, especially among the youngsters, is inability to drink or breastfeed, repetitive vomiting, recent history of convulsions, which implies cerebral malaria, lethargy, and the inability to sit or stand, right? Let's now look at clinical features which allow us to detect severe malaria or features of severe malaria: impaired consciousness, prostration, that is, they are unable to sit, stand, or walk without assistance, multiple convulsions, which means more than 2 episodes per 24 hours, acidotic breathing and respiratory distress, acute pulmonary edema and acute respiratory distress syndrome, circulatory collapse or shock, and urea, which is basically less than 100 moles of urine per 24 hours, right? Jaundice and abnormal bleeding. The lab and other findings: severe malaria, right? Hypoglycemia less than 2.2 millimole per liter, metabolic acidosis with the plasma bicarb of less than 15 millimole per liter, severe normocytic anemia or the hemoglobin of below 7, hyperparasitemia especially above 4%, hemoglobinuria, hyperlactatemia above 5 millimole per liter, renal impairment with serum creatinine above 265 micromole per liter, pulmonary edema radiologically, right? Guys, this is just an excerpt from the Malaria Guidelines that I wanted to draw attention to. Right? It says the diagnosis of malaria cannot be confirmed or excluded clinically. Since the clinical presentation is rather non-specific and may mimic many other disease processes, each patient's blood should be examined immediately using a rapid malaria diagnostic test or microscopy of thick and thin blood smears to either confirm or exclude the diagnosis. However, in some cases, a negative smear or rapid test may not exclude the diagnosis. If the initial rapid test or blood film examination is negative in patients who have compatible symptoms of malaria and no other cause can be determined, there is value in repeating your rapid test or your blood films at 6 to 12 hourly intervals. Repeat tests should continue until the diagnosis is confirmed, the patient has recovered, or another definitive diagnosis has been made. A blood test for parasites should be done irrespective of the time of year or whether or not the patient has taken chemoprophylaxis or traveled to malaria endemic zone. Now, so there is value in repeating your rapid diagnostic malaria test or your thick and thin smears. Very important, guys. High levels of parasitemia, which is more than 4% or equal to more than 3 plus or more than 100,000 asexual parasitized red blood cells per microliter, should be treated as severe malaria. Right? That's over 4% parasitemia. Differential diagnosis, guys. What can masquerade and look and smell like malaria? Typhoid fever, rheumatic fever, primary HIV infection, bacterial meningitis, babesiosis, and other mosquito vector illnesses. Diagnostic evaluation, guys. History and physical exam are the tenets of medicine, and that's what we're going to do. Take a proper history and physical exam, because that indeed can suggest a diagnosis. Light microscopy examination of GM sustained thicker than smears remains a cornerstone for diagnosis and species identification. Alrighty, the smear should be taken every 6 to 12 hours for 48 hours before the diagnosis of malaria is ruled out, although the first smear is positive in some 95% of cases. But if indeed you have a strong index of suspicion and your rapid test or your thick and thin smears have been negative, you can repeat every 6 to 12 hours until the patient has recovered or until you have a diagnosis. Now, newer technologies are available in some labs and include amplification of the parasite DNA or mRNA using PCR for antigen detection with ELISA, for the histidine-enriched plasmodium falciparum assay, for species-specific LDH isoenzymes, and DNA hybridization. Some beautiful pictures here taken from Harrison's, showing us, so in A, we see a young trophozoite, which looks remarkably similar to the smear that corresponded to our clinical case today. This is an old trophozoite right here, Plasmodium falciparum. These are trophozoites in the erythrocytes and pigment in the polymorphonuclear cells. This is a mature cytosol, which is about to burst, right? This is a female gametocyte, see the banana shape, and this is the male gametocyte, right? These are thick blood films for Plasmodium falciparum, and what we can see here are lots of trophozoites, and these are the banana-shaped gametocytes. Alrighty, guys, I just want to talk about thick and thin smears for a bit. Alright, so a thick blood film, advantage is that it is sensitive up to 0.001% for parasitemia, and it helps us to, it's species specific, it's relatively inexpensive. The disadvantages is that it requires experience, right, as artifacts may be misinterpreted as low-level parasitemia, versus a thin blood film, which is rapid, it's species-specific, it's inexpensive in severe malaria, provides prognostic information, right? But disadvantage of a thin blood smear is that it's insensitive. There's, you know, and there's an uneven distribution of Plasmodium vivax as infected red blood cells concentrate at the leading edge. Other modalities we can use are the Plasmodium LDH dipstick or card test, the Plasmodium falciparum HRP2 dipstick or card test, and the microtube concentration, right? And we can also use now the rapid test, the rapid diagnostic test, right? Guys, treatment and management, I want to spend some time on this. So mild disease, as we know, saying it can simply be treated on an outpatient basis with oral therapy, but severe malaria requires supportive care in the ICU setting. And what we are concerned about, right, is that we need to do fluid resuscitation, mechanical ventilation, dialysis, glucose supplementation, anticonvulsant administration intravenously. If in a chloroquine-sensitive region, the treatment of choice is chloroquine, but the distribution of chloroquine sensitivity has, gradually reduced over the years. Plasmodium ovale malariae are uniformly susceptible to chloroquine, but not so with vivax, not so with falciparum, right? Plasmodium vivax and ovale also require treatment with primaquine, but remember, you got to screen for glucose 6-phosphate dehydrogenase deficiency prior to treatment to avoid severe hemolysis. And the reason we do this is to prevent relapse because they remain dormant in the liver. Plasmodium vivax and ovale produce hypnozoites which hang out in the liver and can reactivate at some later point in time. So to treat chloroquine-resistant Plasmodium vivax and falciparum with quinine sulfate plus doxy or mefloquine or halofantine or artesunate. Right, you've got a couple of choices there, but locally we like artesunate and coartem. Due to the high mortality and morbidity associated with malaria and pregnancy, you want to treat with quinine plus Fansidar, right, despite the risk of fetal toxicity, or sulfadoxine plus pyrimethamine. In cases of severe malaria, exchange transfusions should be considered. During travel to endemic areas, protective screens and bed netting are strongly recommended, if not staying in air-conditioned accommodations. Insect repellent containing DEET and permethrin or deltamethrin, which is liquid and spray for clothing and bed netting. Prophylaxis in areas without resistant Plasmodium falciparum. We give chloroquine weekly, starting 12 weeks before travel, during travel, and 4 weeks post. In areas with chloroquine resistance, options are mefloquine, doxycycline, very popular, malarone, which is actually atovaquone, proguanil, and primaquine. Okay, this is taken from the local malaria guidelines. Right, so first up, you want to confirm the diagnosis and assess the severity. Then we've got two arms. On the left, we have uncomplicated malaria. On the right, severe malaria. So if it's uncomplicated, mild symptoms, the order of the day, the patient's ambulant, has normal mental function, there's no repeated vomiting, no jaundice, no other signs of severity. And uncomplicated malaria, by and large, caused by falciparum malaria narlesi, we can give coartem, which is a combination of artemether, lumefantrine, or if coartem not available, oral quinine plus either doxy or clindamycin. If you're unsure of the species, treat us for Plasmodium falciparum. In our setting, falciparum is the order of the day. In case of ovale, vivax, or mixed infections of falciparum plus vivax and ovale, coartem, followed by primaquine. But guys, if we have severe malaria and we define the features of severity already, then usually I'm going to go IV artesunate, but if not available, quinine. Once able to tolerate oral treatment, you can go coartem. If that's not available, doxy and clinda. Okay, this is what Harrison's has to say about this, just to reinforce basically the same information, that in Plasmodium falciparum malaria, we go artesunate, or you can go coartem. Those are our go-to guys, all right? Right, regarding artemether lumefantrine, which is coartem, right, one tablet, just get this in, one tablet contains artemether 20 milligrams and lumefantrine 120 milligrams. So basically, the dosage is going to be weight dependent as noted here. Alrighty. In terms of quinine, which is not really used nowadays, but just to note that one tablet usually contains 300 milligrams of quinine sulfate, and the dose is 10 milligrams of salt per kg body weight every 8 hours for 7 days. Doxy as well can be used, as a tablet which contains 50 to 100 milligrams of doxy per tablet, used in combination with quinine, 100 milligrams twice daily for 7 days, or you can even use clinda as well. Right, how do you define treatment failure in terms of malaria? It's defined as parasite resistance to the antimalarial drug, It could be just due to underdosing or repetitive vomiting of oral meds, non-compliance with meds, failure to take fatty food or milk with coartem, leading to poor absorption of the lumefantrine component. Yeah, so guys, we got to take coartem with a fatty meal. It aids in absorption of the lumefantrine component. Reinfection or apparent, can masquerade as apparent treatment failure. Relapse in Novalia and Vivax because of the hypnozoites. You got to take primaquine for that, right? This is the dosage of chloroquine and primaquine as noted, right? I just want to also mention that severe malaria is indeed a medical emergency. Unless falciparum malaria is promptly diagnosed and treated, the clinical picture may deteriorate rapidly. Severe malaria carries about a 10 to 40% case fatality rate despite treatment. Patients should be treated promptly with IV artesunate or quinine wherever artesunate is not available and be managed in the highest level of care possible. So this is artesunate, guys. Generally, the dose is 2.4 milligram per kg in patients weighing about 20 kgs, and you administer this at presentation, 12 and 24 hours thereafter, and then daily thereafter until the patient is able to tolerate oral treatment. Then you want to give them artesunate orally. This is just a leaflet describing how we're going to go about giving artesunate, right? So what we have is artesunate powder, 60 milligrams, together with a bicarbonate ampule, and then we have saline solution, right? We said the dose is 2.4 milligram per kg body weight, right? And then, so the first thing is you want to weigh the patient, and the second thing, determine the number of vials that you need. So if a patient is less than 25 kgs, you need 1 vial. Each vial is 60 milligrams of artesunate, right? If the patient is between 26 and 50 kgs, you usually need 2 vials. Between 51 and 75 kgs, 3 vials. Between 76 and 100 kgs, 4 vials. How do we reconstitute this, right? So we get the artesunate powder, right? To reconstitute initially with the bicarb ampule, make a little solution, and then you want to shake it up, make sure it's well constituted, and then you want to put in your saline, 5 ml of saline to make up the total dose to be infused, already. And then you administer it, remember, on presentation, 12 hours later, and then 24 hours later, and then daily until the patient can tolerate orally. Right, this is a suggested fluid management in patients who have severe malaria. Right, so you ask yourself, does the patient have a mean arterial pressure of below 65 moles mercury with evidence of decreased perfusion or hemoglobin below 7? If indeed the answer is no, then you ask, does the patient have urine output less than 0.5 moles per kg per hour? If no, then you're good to go, right? But if yes, then you ask yourself, is there anuria? In which case, you're going to really consider renal replacement therapy in the way of hemodialysis. If the urine output is less than 0.5 moles per kg per hour, you give a fluid bolus trial. If no response, consider dialysis, right? And of course, if the patient has ARDS, then you want to consider ventilation, mechanical ventilation for the patient, right? If, however, any of these answer yes, where your MAP is below 65, or there is evidence of decreased perfusion and hemoglobin less than 7, right? If your mean arterial pressure is less than 65 moles mercury, cautious fluid bolus, consider vasopressors, exclude bleeding and sepsis, especially with these patients having thrombocytopenia on the back of splenomegaly and hypersplenism. Empiric broad spectrum antibiotics. If the hemoglobin is below 7, ideally you want to transfuse packed cells or whole blood. Remember, you also want to give them crystalloids. IV crystalloid at about 1 to 2 ml per kg per hour and titrate against the blood pressure and the urine output. Okay, guys, let's talk about prognostication and complications. Plasmodium falciparum can complicate with a whole truckload of complications, everybody. Okay, seizures, confusion, comas, all of that has to do with the nervous system. Renal failure due to hemoglobinuria, something we term black water fever, gastroenteritis, hypoglycemia. Also, hypoglycemia can complicate quinine therapy if you're giving quinine, right? So it's due to the infection itself as well as the sepsis due to the infection as well as the treatment. Lactic acidosis, severe anemia, pulmonary edema, acute respiratory distress syndrome, and splenomegaly. Okay, Plasmodium vivax cause splenic rupture 2 to 3 months after initial infection. Plasmodium malaria can cause immune complex glomerulonephritis with parasite antigen and host immunoglobulin G. The CDC, as we know, maintains a website with information on medication resistance. Areas with chloroquine-sensitive falciparum continue to shrink. Resistance to Fansidar, and Fansidar is a combination of sulfadoxine and pyrimethamine, is growing. Resistance to mefloquine has been found in some parts of Southeast Asia. Okay, guys, features which indicate a poor prognosis in severe malaria. All right, clinical and lab features. So the clinical prognostication features include marked agitation, hyperventilation with respiratory distress, low core temperature of below 36.5, bleeding, deep coma, repetitive convulsions, anuria, and shock. Lab characteristics look at the biochemistry, the hematological, and parasitology. Biochemically speaking, hypoglycemia below 2.2, which is severe hypoglycemia, hyperlactatemia above 5 millimole per liter, acidemia with an arterial pH below 7.25, base deficit above 8 milliequivalents per liter, serum bicarb below 15, serum creatinine above 265, so you've got an AKI, elevated total bilia above 50 micromole per liter, elevated liver enzymes with the transaminases being above 3 times upper limit of normal, elevated muscle enzymes the way of raised creatinine kinase, myoglobin, elevated urate above 600. Hematological poor prognostic cases include leukocytosis above 12, severe anemia with a PAC cell volume below 15%, coagulopathy in the way of a low platelet count below 50, prolonged INR, prolonged APTT, decreased fibrinogen. Parasitology, hyperparasitemia, we said, increased mortality at above 100,000 per microliter, high mortality above 500,000 per microliter, more than 20% of parasites identified as pigment-containing trophozoites and chitogens, but we know above 4% parasitemia heralds severe malaria, right? And the prognosis is worse if it's above 20%. Above 5% of neutrophils contain visible malaria pigment. Looking at the relative incidence of severe complications of falciparum malaria, which are more common, really speaking. So complication of anemia, most severe among kids. Convulsions, most severe among kids. Hypoglycemia among pregnant women and among kids. Jaundice can hit both non-pregnant adults and pregnant women more so than kids. Renal failure, especially in non-pregnant adults and in pregnant women. Pulmonary edema more so in pregnancy, but also occurs to a lesser degree among non-pregnant adults and then kids. Guys, coming back to our clinical case, just to jog our memory, we had a 22-year-old who left her home in Nigeria 2 nights ago, developed fevers in the plane, deteriorating mental status, now confused and lethargic. She's pyrexial, she's tachycardic, hypotensive, thin smear, shows trophozoites of Plasmodium falciparum. What you gonna do? What you gonna do? What you gonna do? IV artesunate. The patient has severe falciparum malaria. The thin smear shows trophozoites in the red blood cells and pigment in the neutrophils. Artesunate, the drug of choice. My friends, just allow me a few moments to speak about some scripture. The Bible says in Romans 11:33-36, starts off by saying, oh, the depth of the riches and the wisdom and the knowledge of God. How unsearchable his judgments and his paths beyond tracing out. Who has known the mind of the Lord, or who has been his counselor, or who has ever given to God that God should repay him? For from him and through him and to him are all things. To him be the glory forever and ever. Amen. When we should think of the goodness and mercy of the Lord, it goes way beyond our limited ability to imagine, leave alone understand. The Bible says his ways are far above our ways and his thoughts are far above our thoughts. God reigns supreme and he's still on the throne. God bless you. Here are my references. I'll see you soon with another handy topic on my channel. You can catch me on Facebook. My page is entitled Internal Medicine, Algorithms and Mnemonics. You can also find me on Instagram and TikTok. Thank you so much for your support. God bless you and have yourself a wonderful day.